I think so. I think with the caveat that you have to be cognizant that it's not you can't sort of start the patient on pembro and walk away from them. You've got to make sure you follow them closely. And the key question is, how do you know can you know early on these patients will respond or not? Because I would argue that you may find, and this needs to be validated, you may find that patients with high volume disease, you may want to start with chemotherapy and then graduate to the checkpoint inhibitor because you worry about losing them at the outset. That's where I think, interestingly enough, a paper that Katie Kelly presented in GI cancer on liver cancer may be incredibly important. For at least, it's the first evidence I've seen of a biomarker that may travel with the likelihood of benefit from these immune therapies, and that is the CD8 population of cells. I mean, something gives, and the real trick is going to be to figure out early on who benefits and who doesn't. As Mike said, the other good thing about the Keynote trial is they have tissue and plasma, and they will be looking, and it will be amazingly valuable if you could, let's say, at 2 weeks or 3 weeks, have some sort of marker that says we're on the right track or we're not, and so you can change gears quickly. But I do think it's a game changer, given the total lack of toxicity, essentially. I mean, mind you, the pembrolizumab is not a walk in the park, so probably 4 or 5% of patients will have a major sort of autoimmune event because of the checkpoint inhibitor, but there's just no real toxicity compared to the chemotherapy, the long duration of chemotherapy. So I think it is a game changer within reason. And we actually have an NCCN call tomorrow where we're going to discuss what we have to do about this. So keep maintaining the guidelines is a challenge. It's nice that it's a challenge. It means that some things are changing at least. So.